Hi, everyone. We're ready for another CCO student webinar. We're at number 99. What does that mean? That means 100 is right around the corner. We'll see you next time on that one, right? With our student webinars, the great thing about that is we are specifically talking about uh, subjects that are going to expand the student experience that you get at CCO. Our students will have access to this content. However, the rest of you get a sneak peek, and we'll let you know more about that in a little bit. I already see some students popping in. Feel free to make comments, and we'll talk about our specific topic as we go along. But that being said, for our students and those of you who are watching us on YouTube, Facebook, and LinkedIn, if there is a uh, particular topic that you feel needs to be unpacked, or you need more information, or maybe you're getting your education and it's just not resonating with you, and you really like the way that we educate, uh, let us know. Let us know what the topic is, and we'll absolutely do a webinar for you based on what it is and where it would be applicable in the different types of webinars that we offer. Uh, it's real easy to do. You go to cco.us /topic hyphen request. So I look forward to seeing what you would like to have more education on. Absolutely, our CCO club members and our students get first priority, and then anybody else that gives us a real good topic, we'll use yours in addition. Today, we're going to look at some practice exams, and the body system that we're going to be working in is neurology. Neurology isn't just the brain. You have the central nervous system and you have the peripheral nervous system. The peripheral nervous system goes out throughout the entire body. And there's other diseases that are affected by uh, neurological conditions and vice versa. And we'll specifically see that in the case that we're going to look at. We are going to be looking at one case, uh, but two different encounters for the same patient. Now, the reason we did that is because in risk adjustment, you're usually looking at multiple encounters and documentation for a single patient. It could be over a year's worth of time, depending on what entity you're doing risk adjustment for. So if you're working for an MA plan, you could have 1,000 pages of documentation on one patient from multiple providers, multiple EMR systems, and so on. But if you're doing pro fee coding, then you're seeing multiple patients, but it's the same provider, same EMR system as you go along. So we're going to come and look at these two encounters with the same case from two separate viewpoints. We're going to look at it kind of from a diagnosis pro fee look, and then we're also going to look at it from a risk adjustment point of view. That way, the purpose of that is, one, you get to, if you've never done risk adjustment, you can see if that resonates with you. And if you like that, brilliant, then come to us and we'll show you how to get the CRC certification. I know you're not surprised that I absolutely love risk adjustment. Then, if you're looking at, maybe you do work in risk adjustment because that's a great way to get your first job, and you're saying, but I've not really done the pro fee thing. It's a little bit of intimidation there. Then you're gonna be able to get a sneak peek of that. Now, today we are not looking at E&M codes, and that would be something that you would see in the outpatient setting. We are looking at the diagnosis codes. Now, we will have a lot of cases where we can go in and do E&M as well. And if that's something that you would like to see more of, then go to the topics request link that I mentioned and tell us that you would like to see E&M cases, practice cases for multi-specialties. All right. Now, uh, the two encounters that we're going to look at again is abstracting. We're going to pull the content from the encounters. And I mentioned that it is two different encounters, two different providers for the same patient. And I'm going to bring up some differences in the way they documented. One's actually a consultation, and the patient has uh, some neurological uh, deficits that are associated to more than one disease process. So, from a office visit perspective, we look at it through different lenses than we do from risk adjustment. They're actual cases, and you may see spelling errors. I went in and tried to kind of clean up some of the spelling errors, but some of them I just thought, just leave them. But I think I got the little lines and things to go away for the Word document. And they've been redacted. We made up a name for the patient and we redacted everything. But the content within the encounter is actually what was documented for that patient. That being said, if any of you guys work in CDI, that's another set of eyeballs. And I'll talk a little bit about that because that plays a big part in risk adjustment. So CDI stands for Clinical Documentation Improvement. We'll make comments about that where we could educate the provider uh, to document a little differently to get their thought process across better so that we can translate it into the code set. Don't forget, I am always saying that we code for statistical purposes. It happens to be a convenient way to get paid. And I like to bring that up when we're abstracting, why it makes a difference that we would want to see verbiage in here uh, for one code versus another code, but the way that it would be translated. Okay, so I want you, when you look at these, to see if you can find any documentation errors. Feel free to put it in the comments. Let us know if you see something. Also, it's always nice to have another set of eyeballs looking at encounters. I went through these with specific purpose, looking for educational things that I could show you. But after a while, when you've read something again and again and again, it kind of blurs. And you know how you get, they say nose blind? You kind of get coding blind or CDI blind. I may not see things that you'll see. So, again, if you see something, make a comment. Let's talk about it. Because by doing so, you're going to be able to help other students that watch this content in the future. All right, the first thing we're going to do, let me just pull this over. And I've made this very big so that you can see it. And I believe that looks good. Jesus can let me know in the background if that's a good size. I'm going to go ahead and make some highlights now regarding different uh, CDI and comments. I'm going to go through it as I would go through it, okay, as an auditor or as a zoom it a little bit more. Okay, so let's just go ahead and go up to 200% and see. There, that looks good. That does make a difference because I'm looking at multiple monitors and I can see what you're seeing, so that should look better. So as I go through this, I tend to go a little fast. If I need to slow down or if you want me to pause and clarify something, put a comment down and I'll absolutely do that. The first thing you do when you're either doing risk adjustment or Profi, and we're going to look at this one from that Profi uh, daily encounter viewpoint. And then we'll go back and look at the same thing from a risk adjustment standpoint, is making sure you always make sure you have the right patient. You're looking up the patient with the MRN number, or sometimes they call it an account number. Now, again, when you do this type of outpatient coding, you know the provider, you're seeing the same encounter format every single time so you know where the provider puts their information on the document, which makes you faster because then you can just zoom right in and say, I want to look at the med list. Okay, okay, okay. I'm going to go see if the surgeries that the patient has. I know exactly where to look. Next, you want to double check that you've got the right patient. I would say that it's always a good idea. Now, you guys will know your patients if you're doing this outpatient type, but it's just best practice to double check your patient and the birth date and the visit date. This is really important with risk adjustment as well. So we have Billy Blue, we have a birth date, and the account number would be like the MRN number. A lot of times, if you're not putting the PMS, the sending it off for billing, and you're using a program to just verify it, put your codes in, and it gets blasted out. Uh, you might be using a spreadsheet. So the information that you would need for that, I'll tell you more when we get ready to do risk adjustment. So there's the patient's account number, there's the date of the visit, patient's name, and the date of birth. I always kind of tend to look at their age to verify that there's not anything wonky going in. Okay, in other words, you're not going to have a 65-year-old person if their date of birth is 20 something, right? All right. Next, why was the patient seen that day? Patient's here for a consultation regarding changes in gait over the last 6 weeks, okay, has weakness in legs, more so on right. Now, anytime laterality is mentioned, you want to make a note of that. Will it be pertinent? It may or may not be. However, whenever we're talking about somebody having a deficit, a weakness, laterality would be important because, like, if they'd had a stroke, we know there's codes that talk about dominant and non-dominant side. So laterality is something that I want to see. So out of this right here, I'd probably go ahead and just kind of make a note of that, more so on the right. Whether I need it or not, that's okay. Now, you will not be able to, you may or may not be able to do this when you are working on the system, the platform that you have. However, you can have a whiteboard, and I have a little whiteboard around here somewhere. I haven't pulled it out in a while, but it's about this big, and then I have my pens and stuff. Or I get these real cheap little notebooks, and I'm telling you, this thing's absolutely full of notes. But what's great about this is I just keep flipping the page, and then I can go back and reference something if I need to. Now, I don't put patient information down. A lot of times when I'm doing this, I'll just square off, like I'll bubble it. But right now, I don't have anything to write down. But I'll let you know if it would be something that I would write down for myself. The reason we use whiteboards a lot is, especially in risk adjustment, is that you're doing one patient after another and you don't need that anymore. And I also have cheat sheets all over my back wall, which now I've pretty much got them memorized, but I can look up and know the difference between, say, systolic and diastolic um, uh, uh, CHF. It was about to escape my brain. And I just look them. Oh, yeah, that's right. That's what that is. So now this may or may not be pertinent. We have something on the right. The patient has gait problems. All right. HPI is really, really important. However, you have to be careful about the information you abstract from an HPI. The HPI is where the patient is being prompted by questions that the provider's giving them to find out specifics regarding what's wrong with them. So a lot of this is per the patient's voice, and that's not a definitive diagnosis. So be very careful that it's not that the patient said that they have, CHF versus the doctor saying that they had CHF. Okay. Now you can reference it, but be very, very careful in doing so. But the HPI gives you the full information of what's going on in the patient. When you get faster at this, if you're new as a student, you're probably going to read more. However, I'm going to show you from a perspective of somebody that's a little more seasoned in how I look at things. Words will jump off the page for me and should for you as well. So this patient has diabetes. That right there is a diagnosis. What's the next thing I ask myself? Are they a type 1 or type 2 diabetic? I want to know that pretty soon. But I'm not going to go and look yet. Although if we look here, I see that the patient's on Lantus and Humalog because the medication list is real close to this. So I know they're a diabetic that takes insulin. Still could be a type 1 or a type 2. At this point, I don't know. So for 7 years, if the patient's been a diabetic for 7 years and I've already seen that they're 65 years old, that tells me they're a type 2 diabetic. Now, not 100% of the time, but 99.624% of the time, you can't be 65 years old and only have had diabetes for 7 years and then not be type 2 or something induced by another disease process. Now, uh, we still have to have the doctor confirm that, but this in a uh, uh, this should blow you out of the water. This is a diabetic patient that has had an amputation. So your little coding brains should be making notes or doing what I'm doing. Now, also, right again. Laterality, always important. Okay. Now, July 20th, osteomyelitis. He doesn't have osteomyelitis anymore because this is August, and and they've already done an amputation, and so this is probably resolved. Maybe it's not, but most likely it's resolved. Let's see, walking without problems, a couple weeks after amputation, imbalance. See, I'm not, he's using a wheelchair. He's dizzy. Recent visit with Dr. Slaughter. History is somewhat inconsistent. All of that is fodder. So I didn't read it word for word, but it's fodder. Nothing that I can abstract out of here. He has no numbness, tingling, da da da. No, when you see no, 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 that means he doesn't have it. I can't abstract anything from that. Now, at this point on this EMR, I want to give the med list a good hairy eyeball. And I purposely only made a few things bold here because a lot of times it's written like this where it's just one big hodgepodge of words. It would be nice if they listened to us where they underlined or made more things bold so they'd be easy to see. Medications prior to visit. Now this is important because that means it's not current. Uh, that means none of this can be a magic line as to an active diagnosis, except for Lantus and Humalog. But I encourage you to know what all of these medications are. They're very, very common. So vancomycin is an antibiotic, and that's why it was given IV. And this was back in August when obviously he had the osteomyelitis. He's not getting vancomycin by IV now. Lantus and Humalog, okay, are both insulins. Whenever you see anything that says unit like this or sub-Q, that also tells you it's probably an insulin. Flomax is usually given to make you go to the bathroom. Aspirin, okay, when you get to be a certain age, you usually are given aspirin to thin out your blood a little bit. Plavix is a blood thinner. Magox is for, if I remember right, it's like magnesium, and they give it for constipation. Percocet is a pain pill, a narcotic. Norvasc, lisinopril, and I may not say this correct, but I call it Labatol. Those are all blood pressure. I think every one of them was like a beta blocker. So those are all blood pressure medications, multivitamin, Cinelax, and Colace, all for constipation. And if you are if you're diabetic, sometimes your digestive tract slows down, but also if you're on Percocet, you get constipated. No known allergy, good. That is fodder to me. Problemless, very important. I want to know what the patient has had a diagnosis of. Cervical disc disorder, amnesia, which is really weird. You don't see that very often. Abnormal gait, idiopathic peripheral neuropathy. So if you don't know what idiopathic means, meaning that it comes from something else, then those terms, I encourage you as a student, you need to be writing them down. Neuropathy should be a diagnosis that you have under your belt because it's extremely common, especially in diabetics. So is there more? No. So we have only 4 things on a problem list. Now, can we approve these diagnoses with the med list? And the answer is no. Maybe cervical disc disorder, you could take a pain medicine and stuff, but none of those medications treat that. And if that's the end of the problem list, where's the diabetes? I think that's odd. That's poor documentation. Okay, so family history. For the most part, nothing in the family history, social history, and stuff is going to be important unless we're dealing with a heart disorder or cancer that we could, that would be pertinent. Uh, but again, most of the time, it's not going to be applicable. And plus, this particular EMR system, he's just going to say that everything was reviewed and pertinent positives are in the HPI. Okay, so that's kind of, in my opinion, a way to get out of making notes. This really is not a very good EMR. Uh, However, I happen to know it's a rather old one. Uh, that probably makes a big difference. So, does the patient smoke? No. Do they drink? No. Review of systems. Now, this should be the good part where we get to find out more about that amputation and other physical findings that might be wrong with the patient. They went, all system is normal in 14 categories unless stated below. The reason it states that is because that's the way they used to do E&M. You had to click those off, those boxes off. This is not a good way to document a review of systems. All of this is fodder to us, but often weight would be included here next to the vitals. And if the patient was, say, a BKA, right? And what type of amputation did this guy have again? Right foot, partial right foot amputation. All amputations of lower extremities risk adjust, but that again we'll talk about that in a minute. All right, the exam. Now, unfortunately, this is a very difficult to read exam. Usually it's not all jumbled up, but let's talk about what we can abstract. The person came in a wheelchair, and it was really hard to get him out of the wheelchair. He's got right hand muscle weakness, uh, vibrating loss. Okay, and so he's a poor historian, so that goes to the cognitive ability maybe. All of this is nothing that we need to look at. The heart, everything's normal, and no lesions, wrath, pulse intact. And you see how the program does not like abdomen soft. It wants us to say abdomen is soft, and we're not doing that. Neurological evaluation, mental station, patient's alert, not aphasic, and cooperative, well groomed, understands and conveys meaning well. Then all these cranial nerve stuff, that's fodder too to us. Uh, Obviously, this is a neurological consult, or you don't really go over it as in depth for a regular PCP per se for these, but there's nothing in here that is a negative that's saying that the patient has a problem. So we skip through it. Let's see, motor examination, no motor drift. Again, da 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 da. Everything's normal. Gait is normal at this time, which uh, if they couldn't get him up, I don't know how they tested his gait, but now uh, here we look at data. A lot of times in this, they will give you tests that were done, but they're saying the patient was in the hospital during these dates and they did a CT scan and without diffuse significant white matter disease with some atrophy reviewed back in 7/7, but we don't know when that was done. So impression, and the impression is the provider's diagnosis. We have a significant gait disorder, which is contradictory to that. So that should be a CDI red flag, right? With a history of being inconsistent, but with a clear recent deterioration. Okay, so we have a gait disorder. Peripheral neuropathy. Okay, so that's a diagnosis. Likely from diabetes. Okay, now I want to tell you something. Normally, if you had a term like likely, that would mean if it said likely peripheral neuropathy, that's not definitive. However, there is a causal relationship between diabetes and neuropathy. So, unless the provider states the patient does not have diabetic peripheral neuropathy, the patient has diabetic peripheral neuropathy. That's a guideline. So, students, you automatically link this diabetes and peripheral neuropathy. This patient is not an E11.9 type 2 diabetic with no complications because the patient has diabetes and peripheral neuropathy. Okay. And is likely contributing. He could also have diabetic plexopathy. That is not definitive. So, oh, wait, I did that wrong. Sorry. Let's do this. That is not a diagnosis. He's saying he could also have this. And that could be contributing to the lumbar disc disease. Okay, so lumbar disc disease, which lumbar is specific. Whenever you have disc disease, they're talking about the spinal column. So you have cervical, thoracic, and lumbar, and then sacral. Where is the disease at? In the discs of the vertebra, lumbar. So we want to make a note of that when we're looking. It's possible that he has cervical disease causing his hand atrophy. So it's possible, that's not definitive, but we know that he has cervical disease, and he means cervical disc disease. So that's another diagnosis. And he has hand atrophy, which is a sign or symptom, and possibly could have myelopathy that is masked by his neuropathy. So again, he doesn't have these diagnoses. He has neuropathy, but he doesn't have myelopathy. Okay. But he has cervical disease, he has lumbar disc disease, he has diabetes, and he has peripheral neuropathy. So that is the neurological complications that this person has. Now, he likely has memory problems as well related to his vascular changes. So, okay, that tells us that there's a CT scan. Now, if you are able, you can go in and you can look at the CT scan and all the CT scans and see if the radiologist made a definitive diagnosis. However, if you're doing everyday outpatient, you cannot abstract that content unless the doctor put it in this note. Now, if you're doing risk adjustment, you can, but this you can't. So we can go and look what the vascular changes were, but unless the doctor brought that information in or gives us a definitive diagnosis, do not code that. and he's going to check the MRI to see if there's any disease changes, to make sure there is no acute ischemic insult, meaning, is there any, uh, again, this is not, everything that I'm doing in red is not definitive. So again, he's thinking that there could be some acute changes possibly happening due to ischemic changes in the brain. The blood going to the brain is messed up. Okay. So these are the diagnoses that the provider picked. Now, you usually get a code with these. The doctor, this is pre-doctor coding. So he's taking a diagnosis from a list and or typing it in. They don't do that anymore. They take it from a list, and there's a code usually pulled from the EMR system. So the doctors are coding. They haven't been trained to code. So we have neuropathy, other specific idiopathic peripheral. We know that that's a bad diagnosis description because the patient's a diabetic. He has gait abnormality. Okay. He has memory loss, and he has a disc disorder, other unspecified cervical region. And then he signs it. Okay. So this, we have 1, 2, 3, 4 codes that are related to um, the neurology. Now let's go look at here what I did with those codes. I pulled out the autonomic peripheral autonomic neuropathy, and that's G90.09. However, the patient's a diabetic, and he did not use a diabetic code. So that's a problem because there's a causal relationship. So this is that's bad. And then R26.9, unspecified abnormalities of gait and mobility. He did not say specifically that these diagnoses were causing his gait and mobility issues. So it is a sign or symptom, and we get to code it as a sign or symptom. Memory loss not otherwise specified. He did not say what the memory loss was. Now, we saw amnesia up in the problem list, but he said he was going to further check the imaging. So that's a sign or symptom code. Most R codes are signs and symptoms. So that's where you're stuck. And then he had cervical region unspecified degeneration, is that what that would be, M50.30. So what's missing? No type 2 diabetes, and he definitely linked that as being complicating the other diagnoses. The amputation wasn't diagnosed. It was in the HPI. So that's a problem. And that's one of the reasons he's having a gait mobility issues. He's, missing part of his foot. And if the patient's a diabetic and it's insulin, we get to code for the insulin, long-term use of insulin. So we've got 4 codes when we should have had this one dropped and then 2 other additional codes. And we don't have the definitive diagnoses on the memory loss and the abnormal gait. Okay, any questions about abstracting from the assessment and plan for this first visit from the viewpoint of outpatient? All right, not seeing. Some of you may be doing that now. We're also going to look at the same encounter and look at it from a risk adjustment standpoint. Then we don't have to worry about the diagnoses that was done for that visit. We're looking at it from a different perspective, and we're going to dig in, grab everything else that we can. And then we're going to look at the next visit with another doctor and abstract that. However, for those of you that are not one of our students or our club members, and you're watching live through one of our social media apps, kudos to you. You get to watch the rest of the presentation free. However, If you're watching this in a recording, you get to stop here because this is exclusive content for our members. If you want access to that exclusive content, as well as a transcript, be able to further have conversations with us regarding what we just talked about and studying it, and a slide deck, uh, then you're going to want to become a member of the CCO Club. And it's real easy to do. You just go to cco.us/club. I'm real curious how many of you guys are already members of the club, how many of you guys are students, or how many of you guys are brand new to a CCO presentation. Take some time, go look at cco.us/club and see the additional benefits that you can get.